So I'm very happy to present Dr. Singer. She is our fearless leader at Metro and a great mentor to me. So she completed her MedPeds residency in rheumatology fellowship training at University of Michigan. She's currently the director of rheumatology for the Metro Health System and the Metro Health Research Capacity Director for the CWRU CTSC and director of the Metro Health Clinical Research Unit and Clinical Trials Unit. Thanks, Dr. Singer.
So I feel like Lenny and my talk could have been interchangeable, but I had his slides before, so I'm going to try and touch on some things that he didn't get a chance to expand on. And also present a patient, because the patients are really, at the end of the day, what this is about. I flew back from New York, I think on March 15th. I was the only passenger along with one other woman and the crew. And as you know, everything shut down after that. But I understood as we undertook a case research committee that rheumatology was going to be heavily involved, because this was going to be like EBV we see in teenagers when it's post-viral. A lot of dysautonomia is what I thought. And that primary care physicians were going to have these patients with vague symptoms and have 10 or 15 minutes to see them and just sort of throw up their hands. And that's exactly, unfortunately, what happened. But I'm hoping we can change that. And so I want to talk about this patient, you'll see, because he has more than one thing. This is a 69-year-old African-American man that I saw in the third quarter of 2021, fall of 21. He had a history of severe COVID, and I emphasize the word severe, and he was ventilated for over a month. He came in with complaints of proximal muscle aching, suggestive of polymyalgia rheumatica, and he got really a lot better with 15 milligrams of prednisone. He did not have any of the symptoms that made me concerned that he had temporal arteritis. He had migraines that were re-triggered, insulin resistance with a hemoglobin A1C in the low 6 range prior to COVID, and we know that COVID worsens insulin resistance or sensitivity to insulin is not as good. And even though he had worked before, he was finding himself unable to do multiple tasks or math in the way that he could to COVID. He was having sleep difficulty despite using CPAP and had some neurologic complaints as well. So the question I think in front of us was, does he have long COVID or PASC? And so one of the first articles that really came out looking at this used the EHR, and as Lenny alluded to, the EHR is fraught with difficulty. We're just sorting through some of the autoimmune disease, and Karen Kostenboder is working on this along with me and several other people, and Karen's even having trouble sorting. We've had to change strategies multiple times. So the EHR can be tough to use, especially since the U9.09 ICD-10 diagnosis was established too late, and so people were diagnosed with post-viral syndrome. So he had a prolonged hospitalization, which was a risk factor for PASC, mechanical ventilation. Remember, early on, we were ventilating a lot of people, and then we just started proning people and gave them high oxygen. He had had premorbid depression and obesity. Risk factors he didn't have is he wasn't female, and he wasn't in the typical, the age group that gets the most PASC. He, by all means, he's male, he's non-Hispanic Black, he should have been lower incidence of PASC. So I want to tell you a little bit about what I've spent the past 3 years working on. This is the Recover adult cohort. This was enrolling at Metro and UH. The study questions, this is a National Health Institute initiative funded through NYU. And they wanted to know what's the incidence, and we couldn't really answer that because it wasn't true population base, but we are trying to answer why some people get this and some people don't, and what are the symptoms. How long do people feel sick? As Lenny alluded to, many people get better, except perhaps the patients with dysautonomia are taking much longer to get better. We don't have directed treatment yet, and we don't know what the immunologic events are that cause it to happen. So when we went into recovery, we were asked to write a protocol. We submitted a grant around March. There were initial centers selected. There were initial centers selected to develop the protocol. We developed the protocol, and then we had to write another grant. And we worked with the 13 other centers of the 15 to make sure that everybody who had really rallied to write this protocol was actually in the second step. And so we were enrolling until about last May. These are the sites for Recover. So you have a wide diversity of institutions and patients. We have almost 15,000 patients. That includes 12,000 with COVID, and people who never had COVID who might have gotten sick during the trial. The study was set up as an observational study, but everybody was getting tier 1 tests, and I'll show you some of those, and some percentage would get slightly more invasive tests, and we're just starting up the tier 3 advanced testing, where there are things that are risk tests. So we have a huge amount of patient-reported outcomes. A minimal physical examination was done, and laboratory studies that are banked at Mayo. And so this is what we initially started drawing. We had triggers, so a 6-minute walk test, for example, might be triggered if you have fatigue, persistent cough, an oxygen saturation that's low. So their triggers were pretty low for phase 2 tests. These are the phase 2 tests. We didn't end up completing the EBV antibody panel, and I now actually have something submitted to try and complete those on people who have certain phenotypes, the dysautonomia, cognitive dysfunction, as well as autoimmune disease. Part of the problem with the autoantibodies, and I'm sure people have had people show up on their doorstep, is the autoantibody panel is now run as a multiplex, and the multiplex is very sensitive for the individual components, and the ANA only gets called positive. The problem with the ANA panel that's multiplex is the pathologists say it's equivalent to a HEP2 ANA, but it's never been validated for classification in our diseases. So I don't know what to do with an anti-RNP of 1.5, for example, in the absence of clinical symptoms. Actually, I do know what to do. I know not to pay attention, but I get a lot of consults about that. And these are the key procedures in adult in the tier 3 that we're starting. Brain MRIs are just starting up. We just had a meeting about who should get nerve conduction studies and EMGs, not a fun thing to get. And so back to our case. So our gentleman weans down on prednisone and he really gets stuck. How many of you had patients with PMR get stuck? Okay, so, and then how many of those people have changed the diagnosis after the patient got stuck and realized that it might be something else going on? Okay, so this is probably one of our hardest clinical decisions to sort out. He had evidence of an amplified pain syndrome and was treated with pregabalin. Prednisone was weaned, and he had been on amantadine from the PM&R docs. If you remember, amantadine, I think when I was in medical school, was used to treat influenza, if I'm remembering correctly. It's not a fun drug to have to take, but it has been used empirically in some patients who complain of cognitive dysfunction. And he comes back in August still having shoulder, ankle, and leg pain, and he's still fatigued. And Lenny talked about the fatigue being an important component. How many people have had COVID or know somebody who's had COVID? Okay. And for those of you who have COVID, Who didn't have fatigue right after COVID? Okay, so a couple of you didn't have fatigue right after. Were you vaccinated? Okay, so for patients who got severe COVID, the fatigue has really been very prolonged. And this is a slide that Janet Mullington at Harvard put together at the BI, who studies sleep. And what it demonstrates it demonstrates the odds ratio of dying if you have premorbid bad sleep. And so you can see that the odds ratio in the orange, if you had bad sleep to start with, goes up if you contract COVID, whereas that's not true if you haven't contracted COVID. And in terms of poor sleep behavior burden, COVID-negative patients have less poor sleep behavior than patients who have never had COVID. And so we encounter this in real life, that patients have a sleep disturbance, and initially what a lot of patients describe as the hypersomnia that you might expect after COVID. But then there's also a period where patients are more awake and can't sleep. And so moderate and significant burden were associated with an increased odds ratio also of being hospitalized. These are the self-reported symptoms that Lenny alluded to that we see in the post-COVID cohort. And the typical domains that this gentleman had is he had some neurocognitive dysfunction. He had fatigue and some post-exercise complaints. He had pain and non-restorative sleep. And these are the things that contribute to inflammation, at least during acute COVID. There's a prolonged inflammatory response, even in patients who get over COVID. There's an initial alpha interferon surge as a response to the virus, which induces neutrophil netting. Then neutrophils secrete the alpha interferon, and they also activate macrophages and other inflammatory cells. Complement systems remain active, and it's the perfect storm for autoantibody production. Early on, you see antiphospholipid antibodies, but I would suggest to you that we don't really know the impact of severe COVID until a decade after COVID in terms of autoimmune diseases, because autoimmune diseases might start with autoantibodies, but frequently don't take a long time to develop. And other risk factors, the population attributable risk, like other diseases we've heard about today, of being overweight, obese, is in the 10% range, and poor sleep is approaching 7%. So these are 7%. So these are really important things, as Lenny alluded to adjust when you're taking care of patients. This was an article published in 2020 where they looked at, it was a meta-analysis where they looked at 1.7 million cases and 50 studies, and sleep problems was pretty near to the top, fatigue being the top symptom. So our patient weaned down on prednisone and got stuck. He had a variety of musculoskeletal complaints. He had evidence of amplified pain syndrome. And I wanted to show you his SED rate and his CRPs. So the first time, in August of 21, this is when we thought he had PMR. The second time, in October of 22, I began to question whether or not it was PMR, whether or not it was only PASC, or whether or not he could have seronegative RA. So we did treat him for seronegative RA, and he has improved. But there are now RECOVER clinical trials because there's no specific treatment for PASC. We've used, empirically, some people use low-dose naltrexone in the range of 1 to 5 milligrams. It's compounded. Not everybody can afford to do that. And I don't think it's certainly not in the Medicare compendium. So the current trial that we're doing is for viral persistence. So the gut can have prolonged viremia, and that's with Paxlovid. How many people have ever tried Paxlovid in the room? Okay, so when my husband brought COVID home in March of 2023 from the Cavs game, He went on Paxlovid, had no problem, ate through Paxlovid, didn't mind the taste. And I thought the only thing that it paralleled was the taste of metronidazole. So I took it at 11 and 11. So patients who have problem with taste of that, we're recommending that. So the viral persistence trial is a 3-arm trial that we're enrolling for now of Paxlovid for 15 days, Paxlovid for 25 days, or just ritonavir, which is one of the components of Paxlovid. But there are other trials coming along. There's an autonomic dysfunction trial that's opening that has low-dose IVIG frequently. That rather than doing 1 gram or 2 grams a month like we're used to doing, it's being done weekly, so it's lower dose. Cognitive dysfunction, exercise intolerance and fatigue, as well as a sleep trial that's opening. So I decided to go through clinicaltrials.gov to see what was out there in terms of treatments. This is the VITAL trial, so the neurocognitive deficits are being treated either by doing complex problems with a central center, but some patients get an add-on of direct transcranial stimulation, and I think that will be interesting. There are trials for brain fog. Somebody in Taiwan has a clinical trial using DAOIB, which alters and it modulates the NMDA receptor. Where else have we heard about NMDA receptors? We've heard a lot about them in lupus, and associated also with cognitive dysfunction. So I'd like to see what happens with that one. Pycnogenol is a nutraceutical that is being tried also in post-COVID in Zurich. So the neurocognitive deficits are most profound, I think, for executive function for people. So people who are really high functioning notice that their executive function is diminished, whereas patients who never multitask in the first place notice other cognitive deficits. There's been a lot in the press about fluvoxamine. I don't think we know whether or not fluvoxamine works. Okay, so fluvoxamine is one of the it's an SSRI candidate. And so there was a very interesting article in Cell that might suggest that this has some biologic basis because with viral infection, and not just with COVID, it's been shown in mice with other infections, that tryptophan, which is absorbed from food, so salmon, dairy, eggs, warm milk at night, is poorly absorbed in the face of viral infection. And the interferon signaling then to the gut, to enterocytes, and this probably has to do also with microbiome, absorbs the dietary tryptophan, and the endochromaffin cells turn it into serotonin. And serotonin, it turns out, is a vagal stimulator. And in the so serotonin is excessively metabolized. So in the absence of serotonin, in serotonin depletion syndromes, what happens is the vagus doesn't stimulate things like the hippocampus properly, and so you can get cognitive effects and brain fog. The other arm of that is that if you get thrombocytopenic during COVID or after it, and especially in some of those hyperinflammatory syndromes, that the hypercoagulability can be associated with thrombocytopenia, and platelets are one of the primary stores of serotonin. And so what you really have in patients with long COVID, some people think, is that serotonin is effectively depleted. And so that might give us a target for how to replete serotonin. How about new onset autoimmune disease? Lenny alluded to this nice study done by Corey Heilman and Shadi Malakuti. I'm on it, and Grace McCumpsey is the senior author. And you can see that there is an overall, the arms were balanced, but there is a fairly representative cohort, 13% African American, I think about 7% Hispanic, and this was done using an electronic tool called Trinetics, which aggregates EHRs, but you don't have patient-level data. But these were the symptoms seen after COVID. There was an increased relative risk of almost 2 of things like cutaneous vasculitis, polyarteritis nodosa, hypersensitivity angiitis, all the kinds of things that you think about that might be associated with neutrophil activation. What didn't we see? Well, for rheumatoid arthritis, at least in this study, there does not appear to be an increase in rheumatoid arthritis. There does not appear to be an increase in SLE or in Crohn's disease. And obviously, we'll have to follow this over time because we're still pretty recent since most of this. This is just broken up as to what the autoimmune diseases are most likely after COVID, less likely, and that they're not associated with increased or reduced risk after COVID. And that should be in your slides. So we did do a working definition that caused a lot of a stir in Recover. And so there was a working definition to try and classify patients. But just like the lupus criteria, classification criteria are not the same as diagnostic criteria. And the patient community was very upset by this because they didn't want to be excluded by insurance saying, you don't have long COVID or we won't cover effective treatments because you don't meet classification criteria. So Lenny briefly showed this, but on the left, table 2, are the symptoms that most likely said that you had PASC. They weren't necessarily the most frequent, but if you had those symptoms, you got a higher score. And if you had a score of 12 or above, you most likely had PASC. Of the patients who had a score that was equal or above 12, we saw post-exertional malaise, which I agree completely with Lenny, needs to be further defined. Palpitations, which might represent dysautonomia in part, or COVID tachycardia. Fatigue, sexual desire or capacity, which is important to patients, and a variety of other symptoms. But those were the most predominant. So what does our patient have? So he has, how many people in the room believe he has some component of PASC? Okay. He's improving, but he fluctuates. His glucose intolerance got worse, which is known after COVID, treated with metformin, Lenny's miracle drug. Not Lenny's miracle drug, but one you mentioned. And seronegative rheumatoid arthritis, and he's now on methotrexate and TNF inhibition. The post-exercise myalgia has improved, but is not gone, and there's no current treatment. So what I wanted to leave this with is most people, as Lenny said, are going to get better over time. The toughest group is really this dysautonomia group, and we're really struggling with how to help them reduce their dysautonomia symptoms. There was a Commonalities of Viral Infection Committee on Recover that now, with a restructure, doesn't exist, but we're still working together and have a proposal submitted to look at things like EBV, as well as some of the demographic factors, including disparities that are based on deprivation and neighborhood deprivation. So I wanted to thank everybody involved. We have been actively involved in Recover, as has Dr. Malakuti, and between Recover and Recover Vital, it takes a village. We've used somebody who's a clergy, Tony Miner at the institution, to help us get to a faith-based ambassador team who can spread the word about what's available. Okay, so do you want people to come back up? So I will finish there, and then I think there's a panel. Just don't forget that patients with rheumatic disease might also have this, and patients who have PASC might also have a different disease, so we still need to think critically about what falls into what category.